or US?
No, I'm in US, sir. Today I'm in Chicago, but I'm based in Buffalo. So I come here every 3-4 months.
Oh, really? You're based in Buffalo now?
Buffalo in sense I have a clinical commitment. In US, I come and I have a research lab here, so I come every 3-4 months. Because of COVID, I have no travel for some time.
Okay. Very nice seeing you after so many
Good,
years.
good.
I'm seeing you.
Yeah, good to see you, sir. You look the same, sir, except for your dress code changed from your white to dark color, sir.
I'm in the theater scrub.
Oh, okay.
Yes, it's evening here. It's
Yeah, okay,
evening and
sir.
the theaters are still on. Dr.
Oh my
Kannan,
goodness.
Dr.
Oh yeah,
Kannan is
I
here.
know. Hello, sir.
You have met him before?
I've seen him in meetings.
Yeah. He's a super surgeon, a super head neck surgeon. He's been my associate for 35 plus years.
Wow.
Yeah.
Baka, call sir.
So how are you keeping, sir?
I'm very well,
Okay.
very well. Hi, Prathamesh.
Oh. Hi, Pratmesh. Hi.
Are we ready to start?
Hi.
I'll just ask.
Hi, Moni. How are you?
Oh, hi. I'm good, Pratmesh. Yeah. How are things?
All well. So, how's it in New York? You
No,
traveled recently, or you've been there for a while now?
No, just 3 weeks now.
Okay.
My daughter joined a college here, then I have my commitment at Roswell, so I club
Yeah,
both.
yeah. Right.
Yeah.
No, good to have you. Always
Thank
a
you.
pleasure to hear you. Yeah.
Yeah, Pratmesh, but I was telling Dr. Pradhan that, sir, I have to leave in about 40 minutes. Unfortunately, I really want to hear the presentation, but unfortunately, I have to leave for another commitment, sir. So if you don't mind, I will leave after about 40 minutes. Sir.
Okay, so we can start right away. Mani.
Okay, sure. I hope you can see my screen.
Yes, we can.
And you can hear me, sir. Okay. So allow me to start. My name is Moni Kuriakos. Really an honor for me to participate in this grand rounds along with Dr. Pratmesh Pai. Dr. Pradhan is a hero for all of us. We have seen him how he operates. It's like an artistry for us. And thank you, sir. Thank you for the opportunity. And sir asked me to talk on a topic which is close to my heart, that is reconstruction of mandibular defect. Sir, with your permission, I added one more word, rehabilitation. I'll tell you why that is important. Before that, sir, if you just look at how mandibular reconstruction has evolved. When I joined my fellowship in US, one of my mentors, Dr. Beckamchen, gave this book for me to read. And it's a mandatory book. He gave that to all the fellows. And most of you in the audience hearing this may not know Beckamchen, but Dr. Sultan Pradhan will definitely knows. He's one of the pioneers in reconstruction. I trained under him. And his time, a lady such as this one, that Lucy Greeley, who wrote that book, had to cover the face, had to undergo multiple operations and so on. So I remember quite vividly taking care of a patient of Dr. Beckamchen. I inherited that person from the previous chief resident, and then I took almost a year to complete that mandibular reconstruction. But this is another patient on the right side, patient I had the opportunity to treat along with the Dr. Iyer, a very renowned plastic and head and neck surgeon. Most of you know him. And if you look at that lady, it's almost like we have reached reconstructive ideals, like we have replaced like with like. Okay. This lady has similar kind of defect, angle of mandible resection. She's smiling or showing her teeth, and about a year and a half out of that treatment, except for slight pigmentation, she's reasonably okay. But rather than accepting that this is a perfect situation, if you ask the patient, she has to spend almost a year and a half of her time in the hospital, multiple operations to get where she is. So we can all clap our hands, say that we have reached somewhere. If you look back from how things were in the 50 years, but definitely the improvement, that's what I want to highlight on that. And if you look at the problem of mandible reconstruction is in this statement, that one word and. We consider reconstruction and rehabilitation as two separate entities. That is where things falter. And that's where things can be improved. This is a patient of mine. If you look at it, fairly good, just a bone replaced and so on. But if you look critically, you can see that there is a the teeth. This is supposed to be the midline, and it's about off by a few millimeters, and the thick hair-bearing skin there. And if a regular patient, other than a cancer patient, come to you, you will not accept it. If a maxillofacial surgeon in the audience, they will know that we don't accept the asymmetry, because that is not. And also we don't accept a edentulous mandible. That is also not acceptable. So how can we move forward? And this is a paper published by Hidalgo. You all know Hidalgo. He's a person who described fibula flap. Some years ago, 2001, he published that 10 years experience of some flap. Only about 14% of the patient could be rehabilitated. Okay. And there are several reasons behind that I will touch upon during my presentations. We'll talk about what are the issues with the bone position as well as quality if I get time. And then how can we address the soft tissue, and then the prosthesis, how can we plan the prosthesis so that the patient will get what he or she wants or needs. So we will look up the bone contour issue. Then I'll talk about the digital workflow for contouring. And that's important because we have Sultan Pradhan sir there, Pratmesh Pai and others, Dr. Karnan and others are here. And they can do marvelous job. So how can we democratize our care so that anyone, anywhere in the world for that matter, can do reliably this kind of reconstruction? And then we need to talk about how to manage soft tissue. We have not reached there yet. Some way to go, but we need to look at how we can manage the soft tissue. And more important, that patient I showed you, how can we condense the period of the entire treatment so the patient can get back to the life. And then, of course, no treatment we do without complications. I'll touch upon some of them. Now, first thing is about the mandible morphology. Now, mandible is a very interesting bone because if you look at the mandible, there are two separate bones actually. One is the bone which is required for attachment of all the muscles of mastication, helping us to open and close the jaw. And second is the bone for the attachment of the teeth. And if you look carefully, these two bones do not align one over the other. There is asymmetry. The two arches, in fact, this is described in this very old publication. And one of my colleagues, Dr. Pillai, looked at that. What is the relationship of this, the basal bone and the alveolar bone? And he looked at in two planes. One is a vertical relationship and a horizontal relationship, and looked at over 100 very standard CT scan and showed that it's about 1.5 centimeter height, and that height is slightly on the anterior mandible compared to the posterior mandible. And horizontally, whether you are in the symphysis or in the molar, overall, it's about half a centimeter inside. The alveolar bone is about half a centimeter inside. And millimeters matters because if you, we are talking about even a very highly precise reconstruction. For example, if you bite on a stone or something, a hard object while you're eating, your teeth will immediately become sensitive, because even a millimeter difference our body don't accept. But we'll get used to it, but that can be avoided. So millimeters matters. Now, as I mentioned before, it's not just a few people doing, like Kannan's mentioned, Dr. Siddhartha mentioned about Dr. Kannan and others. There are very, very expert surgeons are there who can do precisely. But it's not just, we have to take this to thousands of patients. How can we do it on a predictable fashion and much more precise than humans can do? And second is that whether it is possible to make a jaw, including all the components in a day, the concept brought by a group from NYU some years ago in a publication. Now, how can we do that? The workflow of the mandibular reconstruction is that a lot of the work we in the operating room can be done outside before we get into the operating room. So we have to start with the digital planning, plan the entire operation, so the time we spend in the operating room is minimum. Okay, and then that so first there'll be a digital planning. And at this stage, it has to go through an intermediate stage of a physical model using CAD/CAM model. I'm sure in the future, we may not require that, okay? Then we have to make different guides, surgical guides. Currently, it is required, but with improved haptics and navigation, there will be a time when we may not even require this stents and guide. And finally, prosthetic rehabilitation. So to explain the technique, I have this young patient in his late teens, about 18 or 19 years old. He cannot bring the lips together because tumor growing at the angle of the mandible. It was an osteosarcoma, as you can see. There's erosion of the mandible. The primary treatment is resection, and should be a sarcoma resection, so very wide resection we have to do, okay? And then we need to plan the reconstruction. So I'll focus on the reconstruction part. Now, when we are reconstructing the mandible, so we have to look at what should be the final goal. Final goal is what? To get the cosmetic part correct, and we have to get that functional part correct. That means the teeth should be in the right place. So we have to work backwards. So we have to put that teeth where it is. So we can either mirror this teeth from the opposite side. Digitally, we can do that. And then see where the bone should go. As we said, this alveolar component and the basal bone can be, should be in different direction, and that 5 millimeter difference I was talking about, okay? And for cosmetically, the angle of the mandible is very, very important, as well as the parasymphysis area. These two, if you get it right, in between, if you bring it up or down, doesn't matter. Down is not very good, but you can bring it up. So there is there are group which they don't biparallel, they just, sorry, the double barrel, they just bring that the mandible, the one single parallel mandible upwards and leave this open. That gives a very good result. You can put some soft tissue there, that's good enough. But these two areas, there should be appropriate bone contour. And another important point is that, so we have to look at what are the limitations of our bone, which we use for reconstruct. Here we are using fibula, by the way, we use fibula all the time, maxilla or mandible. And then when you're doing the reconstruction or rehabilitation about the morphous smaller region, we don't need the bone all the way to the back, because we put the implants only up to the first molar. If you need additional teeth, we can put cantilever and put teeth behind that. Okay. So anterior posteriorly can be done operatively, and then we can use the guides to get that segments. And this is the proximal end of the fibula. And so we have removed a piece of the bone so that this segment can come above. And this is the least reliable part of the bone. So it doesn't matter, even if you lose that, the remaining bone will be viable. So so that is, we prefer this as the double barrel segment. So before we go to the operating room, we have the pre-surgery model, pre-surgery fibula, and then the guides, and then this is the reconstructed mandible. We can have a printed teeth as well as guides. Not only that, we can pre-bend the plate. So as I mentioned, millimeters matters. So we precisely bend this plate so that the time in the operating room can be significantly reduced. So just to show, this is a guide putting from intraorally around the canine and did the segment resection. Now, my surgical colleagues will say that, or let's say that we in the operating room, if we happens to extend that defect, what's going to happen? We always have two plans. There will be another plan with a distal, maybe 1 or 2 centimeter away, depending on the type of tumor. So that's not a major issue. And while after the resection, the plastic and the reconstructive group will start the osteotomy of the fibula while the resection still goes on. And then they can put the implant in the place. There will be a guide with the accurate trajectory so that the implant can be put in the right direction, because direction is important. So there will be a guide to put that implant. So it doesn't matter where that bone is, the angulation will be accurate. So this is the one which we planned pre-operatively, and this is what we obtained in the operating room, still connected to the leg with the plates all attached. And by the way, you can see that unlike before we used that long reconstruction plate, with this kind of reconstruction, we can use multiple smaller reconstruction plate. I'll come to that. Biomechanically, this is quite adequate, because this is not a load-bearing type of reconstruction, because this most of the bone, there will be bone sharing type of type of reconstruction. And the it's very easy, so right? Once you put that, you take that. This is just looking at from the neck, upper teeth here, low. The reconstruct the mandible, put that the reconstructed mandible into the bone, and the dentist, if you have somebody in there, the audience knows that the position of the implant is very important. It has to go to the right into the groove so that the teeth can be aligned appropriately. So the height is appropriate. And this is looking from the mouth. And here we have even put a teeth there. not because that patient is going to chew on the teeth, but at least the later reconstruction, the teeth can be just replace this temporary teeth with the permanent teeth. And the patient immediately after surgery, and orthopantogram showing that reconstruction, and patient several months afterwards, AP, and looking from the side and looking from below. I just want to point out that you don't need to do a lip split even for a sarcoma resection. We should be able to do just by a transverse cervical incision. Lip split for segmental mandibulectomy is absolutely not required. And looking at the axial scan, you can see that alignment, precise alignment, because we have the cutting guides. And AP showing the condyle, the position of the condyle extremely important because the body humans allow about 15-degree variation in the contour. Anything over that, the body cannot compensate. So alignment is extremely important. And 3D showing that good contoured mandible. Now, the question most of us in the audience or in our back of mind will think that, oh, this costs a lot of money and we cannot do it in India and so on. So that is the reason why we published this paper. We call it Jugaad Technique for Jaw Reconstruction. This was published by my colleague Vinay Kumar. Vinay, by the way, is the brain behind most of what we do. So the idea is that we don't need all the digital planning. It's only the principle of mandible reconstruction, that the millimeter, the alignment of the basal bone and the alveolar bone. So this can be done by very simple low-cost technique. This is a patient with a amyloblastoma, young patient. Plan the resection. And then what we do, we take upper and lower jaw impression, put it in an articulator. Almost all the prosthodontists has that. And we make a wafer, it's a guide, so that that millimeter I was talking about, the 1.5 centimeter height for the alveolar component and horizontal, all that can be built into this intermediate, that wafer. And then what we do for the reconstruction. See here, if you see that we have used that long reconstruction plate. The reason is that we cannot, the pre-plate the segment, because this is what we do the reconstruction during the operation. So their condyle can to be aligned, appropriately aligned. So pre-bend this bent plate can be bent, but we need this long, large reconstruction plate so that the alignment is appropriate, unlike the previous one. So then that intermediary wafer that was put in, and this is before the mandible was, the reconstruction bone was brought in. And just looking from behind, this is that wafer that with that alignment. So double barrel fibula again, lower segment, upper segment, skin parallel. And this is a patient immediately after the reconstruction, skin parallel here, and then the double barrel mandible fibula. Then second stage, we had to remove that skin parallel, put that implant as a second stage, okay, and then complete reconstruction. Now, one of the problem we face is that most of the time after reconstruction, we have this thick skin parallel, hairy skin parallel with a lot of fat there. That it's almost like a mattress. And on top of that, we have to put denture. That will not be stable. And so we developed this technique called subperiosteal, now we call supraperiosteal dissection to prepare the soft tissue. So what this does is that this is fibula here, and this is skin parallel, and they make an incision at the top here, and remove the skin pad, the fat and subcutaneous tissue, bring these to the skin on both sides and put a denture on top of that with the implant. So this undergoes mucosalization. Just to showcase quickly, patient with the ameloblastic sarcoma, resected and put a bipedal fibula here, sorry, and then supraperiosteal dissection. Denture was put in place and undergo keratinization will happen. Histology confirm that on top of that, we can fabricate denture. Patient a few months later. Lastly, very quickly, the timing. Okay, most of the time, as like the patient which I showed you earlier, if it takes about 18 months if we do not have to do radiation. If we have to do radiation, we start the whole thing after 1 year and then do the whole thing. It takes almost 2 years. Now, if you put the implant right at the beginning, okay, the advantage is two advantages. One is that the integration of the implant will take place before the actual radiation starts. So you are almost like a healthy bone, you are putting the implant. Second is entire time can be brought to short end. And finally, as I mentioned, there are no operation without complication. Publication from Vinay Kumar's publication some years ago. At that time, we had about 63 patients, 189 implants, and in the mandible, almost 10% failed. In maxilla, 4 implants failed. When we did a transzygomatic implant, none of them failed. But few of the implants do fail. That is the problem we face. Now, just show you why this failed. One case is like this. In this patient, the superior upper barrel, the entire barrel we lost, along with the fibula, the implant was lost, but the basal bone remained. And second is a patient with a second primary on the opposite side here, and already had a segmental mandibulectomy done. So what we did was we did one fibula for both sides. One same fibula was used for both sides, and we were asking too much. And this fibula we lost, and along with that, some of the implants we lost. To summarize, so if you look at this, is the same points I mentioned at the outline. I moved it up the timing. Timing is important. Planning is important. So that's the first part of any mandibular reconstruction. Then I mentioned about the contouring, the importance of the ankle and the parasymphysis area, digital workflow, and joy in a day. We have not reached there yet, but we will get there at some time. And management of soft tissue, I mentioned, complication. Most of the complication we should be able to address. And finally, I want to thank the team. Even though I work in Cochin now, but most of the work had its origin in Narayana Rudrali, and the person behind most of the work which I showed is Vinay Kumar. Thank you very much, sir, for listening. I'll stop sharing now.
Thanks, Mani. Excellent talk, Mani. Excellent. Some questions, Prathamesh? Dr. Azmat is here with us. She's our microvascular and mandible reconstruction and rehabilitation person.
Hello, hi. Hi, madam. Good evening.
So, Mani, what is happening to the marginal mandibulectomies now with your mandibular reconstructions getting so advanced? Do you ever do a marginal mandibulectomy now, or you've given
all the time, sir? All the time, because makes the quality of life and the rehabilitation become much easier. So the oncologically, the patient can undergo marginal, definitely that's a first choice. Okay, there's no question about that. Segmental is only when it's appropriately, when it is required oncologically.
And how is the rehab program with marginal mandibulectomy?
Yeah, a very good question, sir. So that is a problem we have, because with the marginal mandibulectomy, the height of the mandible is, the alveolar bone is not good. Now, having said that, as I mentioned, most of the time we need the implant only up to the first molar. Okay, and then at 1 or 2 implants, we should be able to place it around that area. If not, we will have to do some kind of bone grafting and so on. It's the double barrel fibula. So we keep that the basal bone where it is. The cosmetic, it is cosmetic, very good. Only for putting the teeth, we put a small segment of bone with the skin. Anyhow, patient need a flap to cover that soft. We take a small piece of bone just to put the implant, but that to me is overkill. So we have done few cases like that, but on a routine fashion, we use some kind of soft tissue flap, and somehow we rehabilitate.
Muni, what about the double barrel fibulas? Do you think that's a good option? And is it possible in all cases?
Yeah, I know, Pratmesh, we use all the time, but having said that, we had number of cases we have lost the upper barrel. Okay, so that is a problem. That's a technical problem. It's the earlier part of our training or procedures where we try to keep the pedicle very long and so on. Now we know that most of the time there are vessels in the upper part of the neck. So we keep that pedicle, we work backwards. So say the length of pedicle from that angle osteotomy, and then see whether we have enough bone for the osteotomy. That is the last part we do. Okay. So then then what we used to do is we try to make the small the piece of bone to remove to swing the mandible horizontally. That initially we used to make as only 1 centimeter, 1.5 centimeter. That's where we used to get losing the pedicle. Now we take a significant bit, so enough freedom to move the upper segment. So we do it all the time. It's a routine procedure. Another option is the group from UK say they move that the entire fibula upwards superiorly and to use for implant placement. That's another option we can do.
There is another method of reconstruction wherein they put the implants within the fibula prior to doing the surgery in order to give more time for the osseointegration to occur. Do you think that is a feasible option? And is our techniques of CAD/CAM refined enough to allow us placement of the implants in the bone?
Yeah, no, Pratmesh, we do implant in the bone only. Okay. Now the technique you are talking about from the Zurich group, they have done that is good for the benign cases where we have time.
Okay.
So you have to expose the fibula, put a skin graft, put an implant there, put a spacer there. Okay, and then you later go, once the soft tissue everything is integrated, healed, you take that the bone for the reconstruction. So that we can do. That takes at least 2 months before the research. So that we cannot do for cancer surgery. Now, the same principle we have tried in 1 or 2 cases but failed. Okay, we can do in situ. Take the whole thing into the oral cavity. Use only the muscle, but avoid even the muscle. Just to take only the fascia and use the fascia for reconstruction. And sometimes we put the skin graft. There's no need for skin graft. We try to do skin graft. Those in situ tissue engineering is something we should try in cancer cases.
Right.
Is there any reluctance to doing the mandibular reconstruction in patients who have a lot of trismus due to submucous fibrosis and a retromolar trigon lesion? We have a lot of reluctance because we want to radiate them quickly and
Yeah.
I don't know what is your opinion.
Yeah, a very good question, sir. And for the residents in the audience, we should never, we are not doing this reconstruction for the patient, not for us. So initially we used to get excited by all this and do all the technique and so on. If you put a fibula in a submucous fibrosis, he's asking for trouble. Patient can't open. If he can't open, you can't put teeth. So we just do only soft tissue reconstruction. Only either we do whatever, either a pectoralis flap or ALT or some kind of flap just for soft tissue. Never, very, very rarely we put fibula. Now, let's say that we have to do a bone reconstruction. We do not connect the fibula to the condyle. We allow the fibula to swing so that it forms a pseudo joint there. Okay, so we don't put a plate with the condyle. Otherwise, become a lot of trismus will be there.
So, do you resect the condyle when you do that, or you leave it?
No. I'd say why should we should do if oncologically we have to take the condyle out? Yes. Otherwise, as a routine, always I leave the condyle there.
So doesn't it form a callus later?
No. I don't think so. Our circuit will have much more experience. So we just leave the condyle there. That will not cause any problem. Because around the condyle, you have the blood vessels, bleeds, and so on. Why should you do it if it is not required? And now let us say at one time we have to go back. Somebody else has to go back and put a fibula, some bony reconstruction. We can use that condyle for later as a secondary. Let's say you have done only soft tissue reconstruction. After 3, 4 years, 5 years, patient want a fibula for osseous reconstruction. If the condyle is there, that would help us to anchor that the fibula. So I don't remove the condyle if it's not oncologically required.
Excellent, Mani. This was a very, very useful talk. Very good talk.
Thank you. Thank you very much. Thank you.
I must admit that even I did not have this concept of mandible being 2 bones. I think it's a wonderful concept that you've given, and that the implants only need to be up to the first molar level. I was not aware of all this. Thank you very much.
Thank you, sir.
Some comments from you, Prathamesh?
No, I always have admired Dr. Kuriakos's zeal to get a very good mandibular reconstruction, maxillary reconstruction. And he has really been after this for the past decade and a half. And he has shown how we can actually give very good quality of life to the patient beyond all our oncologic reconstructions. So I feel that this is something that the youngsters should eschew and strive to achieve, because this is possible today. And it is something that we just need to follow. So thank you, Moni, for that wonderful lecture.
And the vision of democratizing this.
Yes.
And making it widely available. I think it's a very good concept. I was reading a similar article this morning in the newspaper also, democratizing it. Very good concept. And do you have some comments?
Nice, perfect.
With your permission, can I leave, sir?
Thank you very much, Mani. Thanks a lot. Thank you very much.
Thank you, sir. Thank you, sir. Thank you. Bye.
Bye. Bye. Amulya? Ready?
Yes, sir.
Your voice, Amulya?
Sir, am I audible? Hello?
Yes, now you're audible.
Okay. So shall I begin?
Yes, please.
Good evening, sir. Uh, so I'm going to present a case of a lower alveolus. So we have Mr. Khan. He is aged 42 years. He is a businessman from Mumbai and presents with the chief complaints of a growth over the left lower gum, which is there since 3 months. This growth in the left lower gum is for the past 3 months, and it's gradually increasing in size to attain the present size. It is associated with dull aching continuous pain, which is referred to the left ear. He also complains of loosening of left lower teeth over the past 3 months. And also there is foul smelling discharge for the past 1.5 months. There is no history of reduced mouth opening, no change in voice or difficulty in swallowing. There is no sharp teeth or ill-fitting dentures or any other swelling in neck or elsewhere in the body. There is no history of weight loss or any history suggestive of distant metastasis in the form of cough, hemoptysis, and bone pain. There are no comorbidities and there is no prior treatment history. Personal history: he is a known gutka or a pan masala chewer for the past 20 years. He takes mixed diet and he has no other addictions. In the family, there is no history of any cancer or cancer-related deaths in the family. To summarize my history, we have Mr. Khan, aged 42 years with no comorbidities, chronic gutka chewer for the past 20 years with a lesion over the left lower gum for 3 months, which is increasing in size with mild dull aching pain and referred to the left ear, with loosening of teeth and no other history of any neck swelling.
So what is your diagnosis, Mulya?
So my diagnosis, it's a malignant ulcer, sir, of the lower gum on the basis of history.
So what else you would like to know? Any other history you would like to take?
So other history I've already taken in the form of local and regional and distant. So most of it is taught, sir.
Your history taking initially should be towards the diagnosis. So how have you reached the diagnosis based on your history? And is there anything else that we would like?
So first of all, he has addiction to the gutka for the past 20 years, which is one of the prime etiology for oral cancers. This is a progressive swelling, which has been increasing over a duration of time, as well as there is dull aching pain, which is now referring to the ear with loosening of teeth. So this is probably a malignant etiology.
Okay, go ahead.
So in the general examination, he is conscious, coherent, and cooperative, well nourished and built with a BMI of 22 and a performance status of 0. There is no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy or pedal edema. His vitals are normal. He is afebrile. Moving to the local examination, on inspection, the facial symmetry is normal and mouth opening is 3 finger breadth. Halitosis is present. There is poor oral and dental hygiene with carious teeth. There is no submucous fibrosis. We can see an ulcer or proliferative lesion with everted edges over the left lower alveolus, which measures approximately 5 into 3 centimeters, which extends from the first premolar to the retromolar area, which involves laterally the lower GB sulcus, and medially there is gross paramandibular disease. Skin is free and floor of mouth is uninvolved.
Okay.
On palpation, there is tenderness and inspectory findings regarding the dimensions are confirmed, and induration is palpable approximately 5 to 6 millimeters away from visible extent of the disease. Paramandibular disease is there, which extend from the first premolar up to the RMT. Floor of mouth and externally skin are free, as well as there is a single mobile 1B lymph node palpable, and spine, scalp, and other ENT examinations are within normal limit.
Okay.
Systemic.
Anything else you'd like to know? What You specifically mentioned about the pain radiating to the ear. Is that of any consequence in your examination?
Pain referring to the ear means that the tumor is involved deep and going into the inferior, involving the nerve endings of the inferior alveolar nerve, and it's referring to the ear with the auricular temporal branch with a projection.
So you would want to rule out anything in the ear?
Any otitis media, otitis externa in the ear.
So you just need to mention that there is nothing there present in the ear, though there was a referral. So all the areas that can refer to the ear, the base tongue, that is the oropharynx, so extensions onto the oropharynx, extensions into the external canal, those need to be mentioned. Go ahead.
Systemic examination is within normal limit. To summarize my history and clinical examination, we have Mr. Khan, aged 42 years with no comorbidities and good performance status. He's a chronic Gutka chewer for 20 years with the ulcer-proliferative growth over left lower alveolus involving lower GB sulcus with paramandibular spread, with mobile ipsilateral 1B lymph node and a good mouth opening.
So how will you proceed?
I would like to proceed by confirming, I would like to do investigations to confirm my diagnosis, to stage my diagnosis and to treat it. So in the office, I would like to do a punch biopsy under local anesthesia. And then I would refer, and then I would tell the patient to do the CT scan and the blood workup. And I would counsel him regarding the management plan, which entails probably the removal of the segment of the mandible along.
What imaging would you do?
I would like to do a CT, contrast enhanced CT scan of the head neck region from the skull base to the root of neck. Also a non-contrast CT scan of the thorax.
So why would you do the thorax CT scan?
The most common area of distant metastasis of oral cavity is lung. So I would like to rule out first the lung metastasis. Also as a workup for COVID-19, it will tell us about the ground glass opacities and other COVID features in the CT scan.
Right. So did you take a biopsy?
Yeah, the biopsy came out to be a moderately differentiating squamous carcinoma, sir.
And what does the imaging show?
So now here we have a corneal section of the patient which shows a lesion in the left lower alveol.
Can you start with the axial, please?
Yes, sir.
No. Go to the actual scans. Okay, show what you were showing right now.
So the axial is not working.
Okay.
So there is a corneal section of the face which shows a growth in the left lower alveolar, left lower GB sulcus. Just a second, sir. Yeah. Left lower alveolus, which is eroding the bone and mandible and coming onto the opposite side also, sir, with the paramandibular spread.
Opposite side meaning the inner cortex.
The inner cortex, yeah, the inner cortex.
So what are you looking for on the scan?
From the scan, I'm looking for extension. Since it's reaching the RMT area, I would like to see whether it is extending to the infratemporal fossa, the laterally the skin involvement, medially the involvement of the floor and the floor of mouth and the tongue, and anteriorly how much amount of bone has to be resected in the form of spread to the internal medullary canal.
What else?
And the neck nodes, sir.
No, in the mandible, what are you looking for? The patient has good mouth opening. It's more than 3 centimeters. It's a localized lesion involving the lower alveolus. So
Yeah.
what are you trying to look for on the scans?
Whether the condyles, we will be able to preserve the condyles or not. I mean, the ascending ramus and the condyle for later on reconstruction of the fibula.
So you did mention the extent of bone involvement.
Yes, sir.
So we want to know where is the lesion extending to, how much of the bone is eroded,
Yes, sir.
and if the alveolar canal is, infra-alveolar canal is involved.
Yes, sir.
So can you show that? You can see another actual window that will give a better clue. See the one below that? Yeah. Wait for it to load. I think it will loading. Yeah. So you discussed about the involvement of the bone,
Yes, sir.
anteriorly whether it's involving the symphysis, posteriorly whether it is coming onto the lateral segment.
Yes, sir.
What else? You mentioned ITF. So how would you look for the ITF extension?
Sir, I would like to look at the superiorly the base of skull, from there the lateral and the medial pterygoid and the attachment of the lateral.
Show the coronal view. Yeah. Okay. Stop.
Yes.
Stop a little anterior. Come anterior. Anterior. Yeah. Okay. No. It's one move behind. One cut. Yes. So now this is the infratemporal fossa seen very clearly. You're seeing the two pterygoid plates.
Yes, sir. The lateral and
You're
the.
seeing the pterygoid, medial pterygoid coming off and coming onto the mandible.
Yes, sir.
And you're seeing the lateral pterygoid as well.
Yes, sir.
And you're seeing the zygomatic arch as well as you're seeing the mandible.
Yes.
So that is at the sigmoid notch.
Yes, sir.
So you are trying to see for lesion which is above the level of the sigmoid notch or below.
Yes, sir. If it is above the sigmoid notch, it is the high ITF involvement. If it is below the sigmoid notch, it's low ITF involvement.
Right.
So in my case, it was not involving either of the structures. Sir.
Right. So what's your staging in this patient?
So its staging would be a T4A, N1, clinical T4A, N1 and M0, sir. At stage 4A.
Okay. What's your plan for this patient? What's your treatment plan?
So treatment plan would be a left composite resection in the form of wide excision, lower alveolus, GB sulcus with a segmental mandibulectomy with neck dissection, level 1 to level 5 with reconstruction in the form of bony reconstruction. Sir.
What kind of bony reconstruction?
Prefibula osteocutaneous flap, sir.
And thereafter,
And thereafter adjuvant radiation, and depending upon the histopath report, if the clinically it doesn't seems to have lymph nodes involved, so just adjuvant post-op radiation, sir.
so if you had, when would you not do a bony reconstruction?
So bony reconstruction when there is a decreased mouth opening, there is a lot of trismus and submucous fibrosis. In that cases,
What else?
if there are cost constraints also,
More importantly,
if you're not able to preserve the ascending ramus.
no, you have decided that you can save the ascending ramus. You can do a segmental resection.
Yes.
So apart from the possibility of doing a reconstruction, you need to look at the patient profile, his medical comorbidities,
Yes, sir. If
the
we,
feasibility of doing a fibula in the patient, if he has any skeletal deformities,
yes, sir.
and then you'll need to go for social constraints such as costs, etc.
Yes, sir.
So how will you rehabilitate this patient? If I do a hemimandibulectomy
Yes, sir.
and do a primary closure, can I do that in this patient?
So primary closure is feasible in this patient, but the functional outcome will not be good.
So if the patient had comorbidities and I could not do a reconstruction with bone, would that be a good option?
If that is the only option, then we have to do it, sir. And
So how do you rehabilitate a patient when you do a hemimandibulectomy?
so in the post-operative period, we give when the radiation and radiation is finished, we give a bite guide to the patient so that the
When the radiation is finished or immediately post-op?
So bite guide is given post radiation when the fibrosis and all the post-op radiation changes are gone, sir.
And by that time it will be too late. When will the radiation start?
Radiation usually start between 4 to 6 weeks.
And how long will it go on?
It goes for 6 weeks.
So 3 months later, you will give a bite guide processes.
So mouth opening is good, sir, in this patient, sir. The lateral pterygoids are not involved. So the mouth.
So you will want to rehabilitate this patient as soon as he is able to start eating.
Okay.
And you will give a guide plane processes. So it's called a guide plane processes. So you will put a processes so that the patient can get a good chewing action, which will not displace the mandible to the contralateral side and retrain the ipsilateral pterygoid muscles.
Yes.
So the patient will get a guide plane processes immediately post treatment, and he will be using it right through the radiation therapy.
Yes.
Can I do a PMMC in this patient? Will a PMMC be more suitable than a primary closure?
Sir, it depends upon the profile of the patient and which sided he is handed. If it's a right-handed person, then in this case we can do a PMMC in the patient.
So how does it help? How does it help knowing whether he's right-handed or left-handed?
By asking the patient whether he is right.
So why is it important?
Because most of his functions, when he writes and does work, are mostly when he's right-handed, then most of his functions are carried out through right side. So we can compromise a little bit of function on the left side. And
so what functions are compromised when you do a pec major?
So the internal rotation and the abduction.
So he won't be able to eat with his right hand. He won't be able to write.
He'll be able to write.
What are the functional deficits in a patient when you do a pec major?
So limited abduction, overhead abduction above 90 degree, that is restricted.
Right. So you can't do physical labor.
physical labor, combing the hair.
Cannot lift heavy weights.
Yeah.
So the right-handedness is not really critical. It is what is the patient's profession, whether he would want to be lifting weights, doing hard labor.
Yeah.
That is critical.
Yeah, occupation. Yeah.
So you'd like to ask anything?
No, I think he's done well. The bite guide, Amulya,
Yes.
should be given early as Sir has just pointed out. And whenever there is a lot of radiation reaction, he can remove that. It's not a fixed plate. It is removable. If it's irritating him, he can take it off. Intermittently, he will wear it so that the alignment remains and too much fibrosis doesn't draw the mandible away onto the other side. So that's an important thing. If you wait for 3 months and then also wait for him to recover from that radiation reaction, it might be 4 months. So the earlier you give it, the better. As soon as the intraoral wound has healed well, you can ask for a bite guide to be given. Okay.
So,
Is there any role for a limited neck dissection in this, Amulya?
so limited neck dissection in the form of level 1, 2, and 3 with extended taking the level 4 also.
Is that okay to do that?
So is it fine in this patient? Because clinically that is called extended supraomohyoid neck dissection. And we can do in this patient. Level 5 might it can be avoided to do level 5 because it causes complication on the left side, the chyle leak and all.
So which is your preference?
Pardon?
So what is your preference? A comprehensive neck dissection or an extended supraomohyoid neck dissection?
So our extended supraomohyoid neck dissection.
Is it better? Is it
It's
functionally better?
It's better because there will be less deficit post-operatively in the form of nerve injuries in the cervical plexus. The post-operative shoulder dysfunction will be less. There will be less chyle leak. The cosmetic effect of the neck scar will be good.
And supposing you've done an extended supraomohyoid neck dissection and the lymph node is reported positive for metastasis. If you knew that the lymph node was involved, would you do a supraomohyoid or would you do a comprehensive neck?
So if we know that if we know that it's a positive node, then we need to remove level 1 to level 5, sir.
Even if only 1B is involved?
So there are less likely chances to go to level 5, but if lower level necks, level 3 and level 4 are positive, then we prefer to do a full neck dissection, sir.
If you've done a neck dissection, whichever of the two you do,
Yeah.
whether you do extended supraomohyoid or you've done a comprehensive neck dissection, if you've done a neck dissection and the final path report says no lymph node metastasis, what would be your field of radiation versus if it says lymph node was metastatic?
If the lymph nodes are negative, then to the primary and the ITF. And
ITF you prefer to include?
Yes, I would like to include the ITF in this case.
And you will spare most of the neck.
Most of the neck will be spared, sir.
The upper neck in any case gets included in the
Yes.
field of radiation.
Yes. So I would like to ask one question, sir.
Yes.
There is a question in the chat box, Amulya. Would you like to do an MRI to see for the nerve involvement?
Sir, as there is no trismus, and on the CT scan, we cannot find any involvement of the pterygoids. And on the CT scan also, there was no widening of the foramina of this medial mandibular foramina. So it's not required, sir.
Right. So the question was in relation to the pain radiating to the ear
Yes, sir.
and erosion of the mandible.
Yes, sir.
So your answer is right, that there should, if there was any widening of the lingula,
Yes.
if there was a thickening of the nerve at the foramen ovale, you would then consider doing an MRI to actually document the perineural spread.
Yes.
So whenever you have got a lesion involving the mandible and you want to rule out that there is no perineural spread, you would want your radiologist to comment on the widening of the canals, which will give you a good idea about the spread along the nerve.
Yes. So the question I wanted to ask is, what are the absolute and the relative contraindications for doing a marginal mandibulectomy?
So you tell me, in this patient, would you do a marginal? There was very early cortical erosion.
So it was a very gross, the images of the clinical and the radiological findings in this patient were not matching as in the
They're not
CT
matching,
of the
right?
patient. So it was very gross paramandibular disease, and the teeth were all shaky up to the level of the first premolar, as well as the scoopings were also positive. So we have to do an extended. So it was a gross disease with gross erosion of the mandibles.
So if there's a discrepancy, what are you looking for to give you confidence that you should consider doing something less than a segment?
So clinical is more important than the
What clinical findings are critical?
clinical findings in the form of loosening of the teeth. And when we cut the bone, if the giveaway feeling is like
No, clinical. We are not cutting the bone yet. Clinical.
clinical is the loosening
One
of
is losing of teeth. What else?
the paramandibular spread, how much it is there, margins.
So how will you know the paramandibular spread is critical? You can have a paramandibular spread which is very limited,
Yes, sir.
and you will be able to get a soft tissue clearance around it. So how will you know that it is vital that you clear the entire segment?
The most important is the loosening of the teeth, sir. Apart from that,
So the height of the paramandibular spread, it should go all the way down. And when you also mentioned that there's a lingual cortex erosion. So when you have both the cortices which are eroded, it's very unlikely that you will get a safe marginal mandibular resection. When you're going through the bone from outside,
yes,
it's very difficult to actually visualize where the cut's going medially. So by and large, when you have bialveolar bicortical erosion, is very seldom that you can possibly consider doing a marginal.
yes,
So one is loosening of teeth, which is very critical, and the time when the teeth became loose.
okay,
The patient has had a chronic loosening of teeth. It is something that you need to document, or even an extraction. Patients come to you saying that I got a dental extraction done and I got diagnosed with cancer.
yes,
You want to know when the extraction happened. So one is a extraction history, the loosening of teeth, and a paramandibular spread.
yes.
So there's a question that is asked, what is the choice of mandibulectomy in case of significant paramandibular disease without cortical erosion?
Paramandibular invasion itself
Paramandibular disease without cortical erosion. Can you do a periosteal stripping?
so paramandibular disease in itself an indication for segmental mandibulectomy.
Why? So there is no cortical erosion on the bone. There is a infiltrative lower gingivobuccal sulcus growth, which has gone and caused a paramandibular spread. So there is no bone erosion. So can you do a marginal? Can you save the bone? If not, why?
So it's not wise to do it, sir.
Yeah, but there has to be some reason. People must have tried it, right?
Yeah.
what is the route of spread in the cortex? What are the routes of spread?
Sir, in the dentate mandible, sir, it occurs through the dental socket and to the cancellous bone and to the alveolar canal.
Right. So it needs a point of entry.
Yes, sir.
So can it erode the periosteum and invade the body of the mandible?
Yes, sir, it can.
So there are three different routes of blood supply in the bone: the mid segment, the body, and the lateral segment. The mid segment is our point of interest when we are doing a marginal mandibulectomy. And what we need to understand is that the major blood supply of the middle segment is through the periosteum. So whenever you have paramandibular spread, that may cause unknowingly a spread of the cancer within the bone. And that is the reason in paramandibular diseases, we do not consider doing a marginal mandibulectomy. It has been shown from studies from the Liverpool group, Dr. Brown's group, that the paramandibular extension can be vicious and the periosteal breach is unpredictable. If your patient was radiated, it is more likely that you would have a breach of the periosteum. And in those cases, we will never consider doing a marginal.
Okay.
Another question has come up. Would you then consider doing neoadjuvant chemotherapy in these group of patients?
No, sir. In the clearly resectable tumors, we should not.
And there is no cortical erosion and there is a paramandibular spread.
So if it is resectable, first should be resectable because NACT does not help us any overall survival or any. It helps
What
in
about bone preservation? What are the trials which have looked at bone preservation?
Lisitra, Zong, Zorat, these three publications were there who tried the neoadjuvant chemotherapy in unresectable tumors, and they found out that organ preservation rate was
Not
higher.
unresectable. They were resectable. They were resectable oral cancers, but they went with the idea of bone preservation.
Bone preservation.
So what are the preservation? In how many patients they could actually preserve the bone?
So the percentage I don't know, sir.
You quoted all the three trials.
Yeah. So I don't know the exact percentage. Sorry, sir.
So around 52% of the patients we could actually preserve the bone. So that is a good organ preservation strategy when there is no cortical erosion.
So, but calling it as an organ, is it wise to call it as an organ?
What else is the mandible? In context of the oral cavity, it's a functional structure. So you are going to preserve it.
Okay.
So it is organ preservation in the oral cavity. Would you consider doing an MRI in early alveolar lesions with normal CT scans to look for marrow involvement? So what is the role of MRI in imaging of the mandible?
So to know the extent of the marrow involvement, to know the perineural spread.
Can we not know this on CT scan?
Yes, sir, we can do it.
So then how will you answer this question? Role of MRI in early alveolar lesions?
So the early changes are not detected in the CT scan. The MRI picks up the early lesions in the form of perilesion standing and perilesion thickening in the nerve, along the nerve.
What is that called? Not the nerve. What is seen on the bone in MRI?
Perilesion standing, sir.
Periosteal, inner periosteal involvement.
Inner periosteal.
Any other questions, sir?
Okay.
Good. Well done.
Good, Amelia, you did well.
Thank you, sir.
He presented well, sir.
Yes, it did.
So the
Thank you. You have any more questions, Amelia?
So when would we not do a marginal?
And it is not safe.
In an edentate patient, you would
I
not
think
consider
that, I think that all you need to know, Amelia, is that if there is very early cortical erosion, marginal mandibulectomy is feasible. Number two, the bone may not at all be involved, and yet marginal mandibulectomy may be unsafe because of paramandibular tissue involvement. So that is the thing that you have to explain to your patients. That I may have to resect the mandible, and the report very likely will come as bone not involved, and yet in order to clear the soft tissues adequately, I may have to do the segmental resection. These are the two things that you need to know. Early cortical erosion does not rule out marginal mandibulectomy. Certainly, if the lesion is reaching the mandibular canal, definitely it is an absolute no-no for a marginal mandible. And like Sir pointed out very rightly, and you also every time when you see the patients, you see this, that if the mucosa is involved both onto the buccal side as also onto the lingual side, it's very unlikely that that bone can be preserved, and we should not. That you see it every day and you make that decision. So these are the few things that you need to just remember. I don't think the examiner expects to know too much more about it.
So also the marginal nerve involvement and the marrow involvement would not allow us to do a marginal mandibulectomy. So one of the questions are, would you actually do it when only marrow is involved? So if the marrow of the bone is involved, it is very unsafe to do a marginal.
It is very unsafe. It's only for early cortical erosion that it is okay to do it, otherwise you should not. Also into the retromolar region, one has to be one has to think 10 times before doing a marginal mandibulectomy. Once you make those cuts and those muscles of mastication retract, then it is very difficult to retrace those steps. One of the things that you make a judgment on whether or not the mandible is involved, like Sir asked you, is really the visual impression. You very rightly said the loosening of the teeth and the radiology, but the visual impression will tell you that this bone cannot be preserved. Another thing that the postgraduates must know is that if the lesion is involving the anterior arch of the alveolus, then an orthopan tomogram is not a good investigation to judge the bone involvement. Can you tell Amulya about that? To just share it with everybody why that is not a good.
So because the spine superimposes on the anterior segment, sir.
So you cannot really judge the bone involvement.
Yes.
Good, Amulya. You've done well.
Thank you, sir.
Thanks, Prathamesh.
Thank you, sir. Thank you, everybody.
Thanks. Money is good.
Very good. Yeah.